I'm again going to bore you with anemia. Now, having heard about the various aspects of anemia, its bad effects, let us go for therapeutic options. Treatment of anemia, we know we can use oral hematinics for parenteral or blood transfusion. So again, I told very important. We don't start trying alternate day regimens so that the patient confidence also increased. Why towards that? No, exactly. Why towards that? Okay. So it's time to consider the alternate day regimens. If you read the Cochrane data review, it says that oral, even now, the first line of management of treatment of anemia is oral. So it is easy, cheap, and it is written often effective. Okay, not always. But we continue to use, which is not always effective. And we have a complex market scenario. Every day, the representatives come and our molecule is superior, this is at least, that is at least. It is very small in size, very colorful. So many things, they confuse us a lot because we never get updated ourselves most often. Even the best academician is also not updated. So what are the problems with conventional iron that all of you are aware? I'm not going to elaborate on it. So what is the management of anemia? First is medical nutrition therapy. What do you mean by medical? ಎಲ್ಲಮ್ಮ ಹಸಿ ಸೊಪ್ಪು ತಿನ್ನು ನಾವೇ ತಿನ್ನಲ್ಲ ಪೇಷಂಟ್ಗೆ ಹಸಿ ಸೊಪ್ಪು ತಿನ್ನು ಅದನ್ನ ತಿನ್ನು ಇದನ್ನ ತಿನ್ನು ಅಂತ. But of course, this is the main cornerstone of treatment is medical nutrition therapy. And in India, because the prevalence of hookworm infestation is still, if you consider the rural area, it's more than 20%. WHO says whenever there is infestation more than 20%, then we have to debomb. So in Anemia Mukta Bharat, it is recommended that all pregnant women should be given 400 milligram of albendazole once they cross first trimester. Then oral iron therapy, parenteral iron therapy, and blood transfusion. Again, medical nutrition therapy, I am not going to elaborate on that. And debombing, albendazole, Anemia Mukta Bharat, it is one of the important program of the present government of India. Then classes of what are the classification of iron salts? This inorganic salts, that is sulfate, ferric, ammoniums, etc. What are the organic salts? That is ferric, polymorphous, and sucrosomial iron. They are organic salts. Elemental carbonyl iron. For example, the sun pharma has got enophor. It has got carbonyl iron. Chelated iron. Ferrous, bis, glycinate. Chelated iron, because already it is chelated, you are not worried about the foods going to chelate the iron which is present in ferrous sulfate or ferrous phosphate. In that way, they are better tolerated compared to the other. So you should know this formulation. So that is ferrous bis glycinate, because many companies may come and tell you ours is chelated iron. So you are not worried about the food, the phytate tannins going to chelate your iron. Then technological, that is ferrous phosphate. I think the maximum gynecologists, obstetricians, following the introduction of Borophor XT, they are using whatever, you may be using other than the ferrous ascorbate in private practice is the maximum iron molecule which is being used. But government of India gives ferrous sulfate. Either you are using technological iron salt, that is ferrous ascorbate, or you are using, most of us are using inorganic salts. So then ferrous fumarate, the most commonly used, ferrous ascorbate. Again, its high bioavailability compared to ferrous sulfate is more. And carbonyl iron, it is effective, inexpensive, and compared to ferrous sulfate or ferrous ascorbate, the side effects are less with carbonyl iron. But it is said that it is less effective compared to ferrous ascorbate. That's why it's not very popular, carbonyl iron. Then again, as I told, ferrous bis glycinate already amino acid chelated, high bioavailability, it also has got lesser side effects compared to ferrous sulfate or ferrous ascorbate. Then ferric ammonium citrate, bioavailability is very less. That's why again it is ineffective. Most of the iron tonics have got this ferric ammonium citrate. Ferric hydroxide polymaltose complex. Again, it is used as alternate formula. Suppose you keep on giving any iron tablet, you change the brand or from ferrous fumarate to, for example, LIPOSOME to Vorofor XT or any other XT tablets. They have the side effects. Then you can use iron polymaltose complex. So nowadays, this idea is not there because the moment if you think iron tablets are not working, many of us are switching over to IV iron therapy. So response to oral iron, how long we should wait? If at all iron tablet is working, it will start working within 2 weeks of treatment. 1 gram per deciliter increase after 2 weeks of oral iron was an accurate predictor of subsequent hemoglobin response to 6 to 8 weeks. Since we cannot call the patient to come after 2 weeks, or we cannot blood test scan patients. Blood test and they may show the report which is done in Laika, which is very inaccurate. Okay, so that's why when you do scanning at 12 weeks and you start writing the tablets, you again call them. I don't call them patients every month. Suppose once NT scan is done, again directly I call them for anomaly scan. So we have sufficient time of nearly 8 to 9 weeks. By then, if you are whatever iron molecule you have prescribed is not working, then it's high time to get all the iron studies. As I said, CBC, then transfer saturation and ferritin. And if possible, better to write because hardly any difference is there. So if you write every study iron profile, they will get all the saturation, and you can categorically show the patient that see it should be 60 versus only 20, it should be 30. And sir, I request you to write the normal range as 30 and above. Don't write 4. Okay, so patient will get convinced and she will be mentally ready for iron therapy. So don't wait too much. Don't wait for 2 to 3 months to know whether your iron salt is effective or not. So whatever preparation, any company come to you, most of the iron preparation, whether it is fumarate, whether it is a ascorbate, whether it is a ammonium citrate, all are the same. If they are because they are poorly absorbed from the body. Because in the beginning of my lecture, I told that only 1 to 2 milligram is absorbed from the body because of the mucosal block theory, which we have read during. But now they have given a name as Sir said because the understanding of hepcidin has increased in the last 10 years. Okay, so all are saying there is no evidence of one formulation is superior than the other. Only pharma companies make their molecule as superior to another molecule. But in reality, all iron salts are same. Then, when we are talking about hepcidin, there are 2 types of iron, as you are aware: heme iron and non-heme iron. Most of the preparations what we are using is non-heme iron. Heme iron is definitely better, but it is very expensive. Most of the oral preparations do not have heme iron. Only it is present in non-vegetarian, which is independent of mucosal block theory. But in practice, we cannot give heme iron to our patients because the cost is almost 300. 300 milligram of heme iron will only 1 milligram of absorbable iron can be produced. So it's very expensive. So in real practice, it's not possible. We always talk about non-heme iron. So non-heme iron is governed by hepcidin. So then now scientists have started talking about iron molecule which is independent of hepcidin mechanism, that is sucrosomial iron. Sucrosomial iron could be taken up through divalent metal transport protein independent mechanism because all the iron molecules are absorbed through DMT, that is divalent metal transport protein. So it is poorly affected by hepcidin mechanism and maximum absorption occurs even at 30 milligram per day. According to ICMR, we have to give 100 milligram of elemental iron for 10 or 1 to 10 milligram of iron to be absorbed. That is the government of India recommendation, even ICMR. All iron preparations should contain at least 100 milligram of elemental iron. Whereas sucrosomal iron, it works even with 30 milligram and it has got excellent. So this is the new study because the sucrosomal iron has come into last 5 to 6 years. So this is heme iron. It has got a heme transporter and gets absorbed through ferroportin out into the blood. Whereas non-heme iron, food iron contains both heme iron as well non-heme iron, or it could be your pharmaceutical preparation. It goes through the enterocyte through DMT. Okay. So liposomal iron, it has got a phospholipid layer outside. It is called liposome. The lipid capsule contains and carries iron inside. So direct iron is not exposed to the glucose. It is covered by phospholipid layer. So it is confusing the body because iron is not directly exposed to the glucose. It is absorbed by a mechanism called endocytosis. Entire molecule absorbed into the enterocyte by endocytosis. It is not by DMT mechanism. So this is the typical picture of the oral iron. It's called as inside ferric pyrophosphate is there, and also because of the government regulation, it should contain folic acid. Whereas outer coating is phospholipid layer. Because it is a phospholipid layer, it absorbed through the body by endocytosis. So elemental iron through DMT is the regular whatever we are using. Whereas liposomal iron, it is by endocytosis. So conventional iron absorbed in the duodenum, whereas sucrosomal iron throughout the small intestine, and it is by duodenal enterocyte, conventional iron, whereas sucrosomal iron is by egg cells. Acidic pH is definitely required. That's why they started adding vitamin C, or we'll ask them, or ferric ascorbic itself has got vitamin C. Whereas such a requirement is not there for sucrosomal iron, and absorption may be affected by proton pump inhibitors. Most of our patients will be taking some rabeprazole or omeprazole. It's very common, but such a thing is not there for sucrosomal iron. Again, it is affected by phytate, tannins, calcium, milk, everything. And because it is transported through divalent metalloprotein, even if, because sometimes your tablet itself may contain a lot of trace elements, zinc, magnesium, this, that itself will again reduce the absorption of iron. So if at all you are writing iron, write only pure iron. Don't use iron which contains a lot of other trace elements. So such a thing is not there for sucrosomal iron. And increased oxidative stress itself can cause iron what is absorbed from the regular salts itself can damage the enterocyte. So they have studied that the response of sucrosomal iron is better, and it was almost equivalent to IV iron according to the study. So as I said again, treat anemia before 30 weeks because brain development is dependent on iron in the maternal blood. We have to correct anemia before 30 weeks. Again, this is very important. India, every alternate patient has got gastritis. So H. pylori infection is very common in India. So individuals with incomplete response to iron must be treated for H. pylori, peptic ulcer, gastritis. This is very common. Almost 50% of Indian women are suffering from this. And again, whatever you tablet, it won't work because of the potential infection. Because of the H. pylori infection, again hepcidin is increased. Mechanism is same. Because of the inflammation, gastritis, again hepcidin is increased. So unless you treat gastritis, your oral iron therapy will not be effective. So what is the take-home message? Daily versus alternate day dosing. Alternate is better. Number of doses per day should be given. Suppose patient is 8 gram, every tablet to one time. No, it is not going to work. No need to increase the dose. Amount of iron per dose. So again, ICMR has to the rethink. Earlier we were giving 60 milligram of elemental iron. Now they recommend 100. So lower the better. So this is the take-home message as far as oral iron is concerned. Whether oral iron works, what are the side effects? And patient should have constant internal motivation to take tablets. Daily tablet with uncold it's not at all possible. According to the recent survey, only 10% of Indian women take correctly as advised. And we don't check whether they are in case. So the problem of side effects, lack of motivation, the myths, ಟ್ಯಾಬ್ಲೆಟ್ ತಗೋಬಾರ್ದು ಅಂತ ಹೇಳೋದು. ಯಾರು ಹೇಳೋದು? ನಮ್ ದೊಡ್ಡವ್ರು ಹೇಳೋದು. ಅವ್ರ ಹತ್ರ ಡೆಲಿವರಿ ಮಾಡಿಸ್ಕೊಂತ they come for us for scanning, but ಕೂಸು ಬಲಿತದೆ. So the lot of myths and misconceptions. ಆಯ್ತು ಅಂತ ಹೇಳಿದ್ರೆ ಅವಾಗ ಹೋಗ್ತದೆ. So hepcidin decreases absorption in response to infection. That means anemia begets anemia. So way back in 1949, Scott and Gowan in Lancet, they have written, if oral iron does not work, switch quickly to intravenous iron. Don't waste your and your patient's time on oral iron. Old and words way back written in 1949. That in Lancet. So parenteral iron is the right solution. IV iron acts like an active immunization. Blood is like a passive immunization. Always better to have our own blood. So parenteral iron is smarter, better, and faster. IV iron is smarter, better, and faster. So what are the indications for iron? Poor tolerance to oral iron, 34 absorption, non-component. Women with moderate to severe anemia near term, we have to use. Suppose if patient does not have the opportunity to come to it, even at near term, maybe at 36 weeks, don't treat with blood transfusion or oral iron. Switch quickly to IV iron. Parenteral iron, it is the perfect gap between oral and blood transfusion. So what? Then coming to the IV iron, what are the types? Type 1 complex, thermodynamic but is strong, that is ferric carboxymaltose, and iron, that is a new molecule, iron isomaltose. They are all type 1 complex. Moderately strong, iron sucrose. We were the first people in Karnataka, maybe in India, to use IV iron sucrose for pregnant women. So we made a recommendation to our national brother. That time Hema Dibakar was there. She took up the matter, and from then onwards, government of Karnataka is regularly using iron sucrose, but it is working. But the problem is they use only 100 milligram. They give 100 milligram, and many times they don't treat the concomitant B12 deficiency. In spite of receiving a lot of iron in the periphery, and their iron is not increasing, and maybe again government setup means whether that quality iron sucrose they are providing. So many issues are there, but still iron sucrose is being used at peripheral level. The type 3 complex are older than injectable insulin, all those things. Nowadays we don't talk about that. So first generation, again, either type 1, type 2, type 3, or should use the terminology. We are using third generation of iron molecule, that is I3, iron isomaltose and FCM. So whether it is FCM or iron isomaltose, they have got a strong carbohydrate shell. The iron hydroxide inside is tightly bound within the carbohydrate cage. The molecular weight of both iron isomaltose as well as FCM is around 1 lakh, around 1.5 times. This makes more difficult to break down. Easily it is not released into the systemic circulation. Again, the comparison. So it has got a strong carbohydrate shell. Iron dextran has got a low molecular dextran. Ferric gluconate is a gluconate. Iron sucrose is a sucrose. Whereas FCM and isomaltose, they have got a carboxymaltose or isomaltose. They are stronger carbohydrate shell. What is the importance of this carbohydrate shell? Every parenteral is complex with carbohydrate moiety, which holds iron till the iron complex reaches the liver and spleen. It is not released in the blood. Whereas iron sucrose or other molecules can easily release the iron in the blood itself. So more stronger is the complex, more safer is the parenteral, because it will release less level, and free iron is always dangerous in the body. Why you cannot give iron sucrose 1000 milligrams? Because it is easily broken down into free iron in the blood itself. So a lot of free iron is available in the body, in the bloodstream. So it is very dangerous. It can cause parenchymal damage. That's why you cannot give iron sucrose more than 200 milligrams. Whereas FCM or iron isomaltose, they are not easily released in the blood. So they are safer because they are directly transported to liver and spleen where reticular endothelial system is there. So tolerability depends on the size of the carbohydrate complex. For example, the iron sucrose molecular weight is between 34,000 to 60,000 daltons. And FCM or iron molecule is 1.5 dalton. Why government the iron they are not working? Maybe because of the low molecular weight. Standard companies use they go by the quality standard where the molecular weight is around 60,000. Is structure similar to ferritin. The medium lethal dose. If you read this, you get convinced to use IVR. Ferrous sulfate, median lethal dose means the dose at which 50% of the mice are killed. The laboratory mice are killed. That is LD, lethal dose. Ferrous sulfate is 11 milligram per iron per kg body weight. Iron sucrose is 2,200 milligram. Whereas FCM or iron isomaltosate, the median lethal dose is more than 1,000 milligram per kg body weight. Whereas in clinical scenario, only we use 500 to 1,000 milligram. So that's why it is very safe. Again, I am repeating this: free iron is toxic. If you give iron in the presence of infection, because all the transferrin ferritin they are busy in fighting the infection, so this your iron will not be carried by transferrin. So easily free iron will be available, and it is highly toxic. So don't use IV iron in the presence of inflammation or infection. Why FCM or isomaltosate have low level iron? Because they are slowly released into the system. So iron isomaltosate newer molecule, it is third generation IV iron compound introduced in Europe in 2010. In India also it is approved way back in 2013. We never knew about this. Now we are almost 10 years later we are talking. And approved recently by FDA in 2020. And there is a study going on in India. It is called rapid iron study. Rapid iron study. One of the, I think, Raichur is also a part of it. Results yet to be recruitment is according to the data. Recruitment finished by February 2023, and Raichur is one of the epicenter for use of iron isomaltosate. Iron. So initial complete parental repletion for rapid improves clinical outcomes, and the importance of using FCM or iron isomaltosate is reduce healthcare visits. Whereas for iron sucrose, every time you have to, the integrity of the vein is lost because you are repeatedly pricking the vein. Such a thing is not there for FCM iron isomaltosate. Only problem is they are expensive. FCM is almost 3 times costlier than iron isomaltosate. So what are the contraindications? Liver dysfunction you should not use, acute or chronic infection, and even though it's a category B drug, we usually don't use in the first instance. If really necessary, we can use, but by and large, usually we don't try to avoid unnecessary drugs in the first instance. And all of you are aware of this, but many people give it like a blood transfusion. They give FCM in 500 normal saline, and they give 500 normal saline. It goes for 4 to 5 hours. Then the whatever molecule it become unstable, and it can get dissociated because of the atmospheric pressure, atmospheric light. That's why all the iron wires they are amber color. They are photoresistant. Suppose if you put the FCM or iron isomaltosate 500 normal saline and run it like a blood transfusion, it can create free iron and it may be deleterious. So never use in a 500 normal saline. It should be 500 or 1000 mg if at all you are using. It should be diluted in 100 ml of normal saline and it should be run for 15 to 30 minutes. So whether pre-medication is required, no pre-medication is required, and no test dose is required for iron isomaltosate. But always it's better because sometimes we come across some reaction. If you ask them, they may be having some allergies, multiple drug allergies, or atopy may be there. I've seen most of the patients who have got asthma are more likely to develop reaction. So you ask the history of asthma, if such a history is there, you can give methylprednisolone IV 40 mg. If patient is having, or you can give hydrocortisone, which is easy diagnostic. Suppose if if you start iron isomorphoside or FC, this patient develops rashes. No need to stop infusion or no need to totally discard it. You can give hydrocortisone or the methylprednisolone. Wait for the symptoms to subside. Only in case of respiratory reactions, patients are a lot of breathlessness. Then only you should not again reuse the FCM because it's very expensive. One drop last model. Only in severe anaphylactic reaction, sometimes it can happen. So that's why we should such a thing is that you do either methylprednisolone or hydrocortisone. And minor reactions, some itching and all those things, you need not discontinue the medication. You use all these things. Once it's upset, you can restart. So again, any reaction we are in the process of giving away, we should not give. Better to use hydrocortisone or use methylprednisolone. Don't give away. According to the so much of study, no fatal reactions found out and appear exceedingly rare. Say it doesn't. Sometimes you can develop any reaction. It is exceedingly rare. So compared to blood transfusion, put in perspective, number of adverse reactions are higher in blood transfusion at a rate of nearly 1 in 21,000 for FCM or isomorphoside compared to blood transfusion. Almost 100 times it is safer compared to blood transfusion. So when we are recklessly using blood transfusion, if you read this, you will have a confidence to use IVF. Again, response depends on pre-existing HbA. Lower the value, better the response. Suppose you use for 6 gram hemoglobin and for 8 gram, the person with 6 gram will prove better. That is again because of the all these 6 low hemoglobin level, they have what high erythropoietin output. Whenever erythropoietin is more, it quickly takes all the IVR and the response is better. And HB rise may be evident as early as 5 days. This is given in older edition of Harrison principle supplements. So again, it is recommended that in severe iron deficiency anemia, less than 80 gram, whatever the cause, instead of trying with oral hemoglobin, use IV iron. So what are the indications? The indications established are failure of oral iron, malabsorption, severe IDA, or chronic kidney disease, pregnancy, heart failure. Extended uses, you can use elderly patients or perioperative anemia. Again, I told don't use blood transfusion, use FCM or iron isomorphoside. Some people have restless leg syndrome. All and you give vitamin D3, you give magnesium, they don't subset at all. But for such women, if you give IV iron, most of them will feel better. And mountain sickness and heavy uterine bleeding. So another, when you compare with FCM or iron isomorphoside, chance of hypophosphatemia in FCM is almost 10 times more. Again, they have done a study in UK comparing iron isomorphoside and FCM, an indirect treatment option. They found out better results with isomorphoside compared to FCM. And at a time, you can give only 1000 milligram of FCM, but in the literature, it is recommended that iron isomorphoside can be given up to 1500 milligram. Regarding hypophosphatemia, it does not have any clinical relevance. She will claim that hypophosphatemia is not there, but the available literature says that it does not have any clinical relevance unless patient has got parathyroidism, hypoparathyroidism, or osteomalacia. So clinically, it is not significant, but the advantage of iron isomorphoside does not cause hypophosphatemia. So it also increases the iron content in maternal milk. That is the biggest advantage if you use iron, especially if you use in the postpartum period. You are we cannot give iron supplementation to the newborn, but by increasing the iron content in maternal milk, you are helping the next generation. And you should make it a policy to give iron, IV iron in the postpartum period because of cesarean section, many of them have lost their 11 gram would have become 9 gram. So it is better to give at least 500 milligram of IV iron before you discharging from the hospital because once delivered, mission is complete for them. They don't come for health surveillance unless there is a problem. So by having a regular postmortem protocol in your hospital, all patients you must give IV iron before discharge. And it is the doctor who make the treatment costlier. He made the total. Even IV iron costlier than nobody uses. So that was the earlier when they were using levodopa. Levodopa is cheaper, levodopa is costlier. So it's costly and but we ourselves take costlier the cloths. Okay. So if the doctor tells, definitely a patient will take. You reduce your fees, advise the patient to take IV iron. Definitely you are doing a great service because they will be out of health surveillance once they are discharged from the hospital. So that's why in our units, whether it is iron sucrose or something, we give them and before discharge. To make it a protocol, routine protocol in our hospital before, because anyhow, iron sucrose or FCM is available free of cost in our hospital. So IV iron drug market. Just look at this. There was only $641 million in 2006. It is expected to reach $2 billion by 2026. So they are not considered India. If every gynecologist in India start using IV iron for the benefit of the patient, this could even reach more than this. So what we should have focused antenatal instead of calling them every 15 days or 1 month. As written in the textbook, we do not use. Calling it only for except for high risk patient or low risk women. Definitely you can have focused antenatal visits. That's what most of us are practicing. Call them at 12 weeks, again call them at 20 weeks. So every visit has got a purpose. Suppose you are calling at 12 weeks, you are calling for NT scan, you are calling for basic blood test. Then again at 20 weeks, you are calling for LIPOSOME scan and also to know whether whatever iron you are giving is working or not. So, early replenishment of hemoglobin is the need of the hour, especially in high risk cases. Every obstetric unit I told must have a policy to treat postpartum anemia. Blood transfusion only for life resuscitation in acute cases, not to treat the anemia. So many times patients may have 5 gram or 6 gram, they are absolutely fine. So we have been taught that any severe anemia, irrespective of the gestational age, you must treat with blood transfusion. That is drilled into our mind. So now we have to rethink, and that's what we tell our undergraduates and PGs also. But you can rethink, you can avoid even blood transfusion, even the second trimester, unless patient is going to deliver every another 1 to 2 weeks. There you can use blood transfusion. But the mid trimester, if 5 grams, 6 grams is there, we don't use blood transfusion at all. We will give them for a longer period and then give IV iron. Healthy generation next is our responsibility. Actually, after this, we are responsible for the healthy generation, and also we are very much responsible for women. So again, I want it is to create a better life for our women and our next generation. It is the primary responsibility lies with the obstetrician, not with the physician. Thank you for your question.